Bhanu, please start.
Sir, my slides are visible.
Yes.
Dr. Prashant, my slides are visible.
Yes, Bhanu, your slides are visible. Bhanu, your slides are visible. Please start the session.
Okay. So once again, good evening, everyone, and I hope you all are doing well and great at your home. So I'm Bhanu on behalf of Discovery Mankind. Would like to welcome you all for joining us today and gracing this occasion. But before starting this event, I would like to give a quickly brief about my company, Mankind Pharma. So Mankind Pharma is one of the top leading pharmaceutical company in India, and it has been established in 1995 by Mr. R.C. Juneja. And it's my privilege to announce that it is the #1 company as per the prescription audit, and it is the #4 ranked company as per the IQVIA data. If I'll talk about the revenue, it's $1 billion USD, and apart from the strong presence not only in the prescription drugs but also in the OTC and veterinary medications. So our core philosophy is serving life, which has been based on the three strong pillars like quality, affordability, and availability. And these are the few milestones which we have jotted down. If I'll have to pick and choose few of them, so it is launched in US operations, and our few of the plants get US FDA approved for the finished dosage form. And in this pandemic, Mankind Pharma has shown the gratitude by contributing the 100 crore to all the medical fraternity. If I'll talk about the various therapies and the range, so our Mankind Pharma is having the strong presence in anti-infective, GI portfolio, cardiovascular, and anti-diabetic, and so on. So we are having the world-class R&D development facility, which includes new drug discovery research, API, formulation, and biosimilars. So this is the first time that we got the worldwide patent for novel anti-diabetic molecule, which is GPR 119. So with this, I once again say thank you to each one of you for joining us today and your continuous support and encouragement for us. So I would like to hand over the session to Dr. Prashant.
Thank you, Bhanu, and thank you everyone who have joined us here with another exciting session of Diabetes News Nucleus. In this session, we always bring you the latest updates and the expert analysis of those news, whatever happening in the diabetes world across the globe. And in today's session, we are going to discuss about the AACE conference, which recently happened, and American Diabetes Association conference, which also completed in June. So with this, I now invite our speakers for this session. Next. With Dr. Rajiv Kovalser, who is the moderator for this Diabetes News Nucleus, and he is Medical Director and Consultant Diabetologist at Dr. Koval's Diabetes Care Center. He is a well-known name in diabetes world and also Consultant Diabetologist at Nanavati Super Specialty Hospital and SL Raheja Hospital and KLS Hospital Arogya Nidhi and BSES Hospital, Mumbai. He has been invited faculty at many programs and diabetes fellowship program at D.Y. Patil Medical College. So I welcome Dr. Rajiv sir to moderate this session. And I also like to invite and welcome Dr. Mala Dharmalingam ma'am, who is the expert guest speaker for this session of Diabetes News Nucleus. Dr. Mala Dharmalingam is a well-known name in endocrinology across the world. And she is Senior Endocrinologist and Head Department of Endocrinology at Ramaya Medical College, Bengaluru. She is active researcher with more than 150 trials and more than 130 publications to her name. She has been awarded by Economic Times for the most inspiring doctor and awarded prestigious Dr. B.C. Roy Award and Academic Excellence Award. She has been past president RSSDI Karnataka and past vice president of Endocrine Society. With this, I welcome Professor Mala Dharmalingam ma'am as well, and I hand over this session to now Dr. Rajiv Kovalser to take the proceedings further. Dr. Kovalser.
Thank you so much, Prashant. Welcome to the 9th edition of the Diabetes News Nucleus. This is an initiative by IJCP and MedTalks, and the whole endeavor of diabetes news nucleus has been supported by Mankind Pharma. This endeavor and this initiative, our whole vision is to make sure that we get you the latest in the metabolic space, whichever is happening across the globe during this month, to use so that it can enrich your practice. And today, as Dr. Prashant said, we have none other than a renowned expert in the field of endocrinology and the metabolic space with us, Dr. Mala Dharmalingam. But before we have an expert commentary from her, let's have a look at the headlines. The headlines, please. So antacids have always been an abused thing in across the globe, probably the most abused thing. But have you ever wondered that antacids could actually improve blood sugar? We knew that antacids were related to progression of chronic kidney disease. But a latest meta-analysis which got published in the Journal of Clinical Endocrinology and Metabolism says that antacids improved blood sugar control in people with diabetes, but had no effect on reducing the risk of diabetes in the general population. Pretty surprising. The researchers also found antacids can reduce HbA1c by almost 0.36% in people with diabetes and lower fasting blood sugar by 10 milligrams based on the results from 7 clinical trials. Now let's look at obesity, and obesity is also occurring prematurely in India. We all know that India has this twin epidemic of premature diabetes and premature heart disease, but premature obesity seems to be the mother of both these things. And the offshoots of premature obesity is premature heart disease and premature diabetes. And this research says that teenagers with obesity were more likely than their slimmer counterparts to have a heart attack, diabetes, or poor health when they reach their 30s or 40s. So basically, we need to catch them young. Teens with obesity are more likely than teens without obesity to have high cholesterol, high blood pressure, kidney disease, heart failure, and cancer. And this BMI cutoffs, we spoke last month about certain BMI cutoffs and how ethnicity could play an important role. If I could just refresh, a large such study showed that the BMI cutoff, which today is looking at progression towards diabetes for the white population, is somewhere around 30 to call them obese. For South Asian Indians or Indians, Bangladeshis, Sri Lankans, Pakistanis, the cutoff is somewhere around 23.9. For people with Chinese origin, they saw that it was something like 26.6. For people from Middle Eastern origin, it was found to be 26.9. So there are going to be ethnic cutoffs in periods to come, and probably diabetes, lipids, everything may have an ethnic cutoff over a period of time. Let's look at another headline of a double lethal combination of diabetes and sleep disturbance. Adults in UK biobank with any form of self-reported diabetes or insulin and who had sleep disturbances had a significant 87% higher mortality than those without diabetes and those who said that they never had sleep disturbances. So diabetes who have sleep disturbances are at 87% higher risk to develop an event as compared to people without diabetes and without sleep issues. So probably sleep well, relax well. That's extremely important to prevent chronic care issues and chronic problems also. Now, we all know that over the last few years, time in range has become a very important surrogate marker. It's probably a new promising tool. Till now, we are looking at HbA1c as one of the best surrogate markers of glycemic control, and all our prospective studies have always been on HbA1c. But today, probably CGM, time in range, could be a very important marker. A new study from what we call as the next generation CGM, which is an implantable CGM of 180 days, which is called Eversense. It's by Senseonics. Earlier, it used to be by Roche. Shows that this kind of an implantable CGM, which works for almost 6 months, has only a MARD, which is the mean absolute relative difference of 9.1%. So the future may be that we may have implantable CGM to actually take care of the excursions and the glycemic variability that we have and we experience in patients with type 1, type 2, as well as gestational diabetes. Now, let's move to the topic of the month. So the topic of the month is about the American Diabetes Association and the American Association of Clinical Endocrinologists, and it was a sort of a year that none of the people in the metabolic space, diabetologists, endocrinologists, should have missed, because a lot of data emerged. And today we have Dr. Mala Dharmalingam, who's a very senior endocrinologist from the MS Ramaya Institute in Bangalore, to give us a pulse of wisdom. She's inspired a lot of people, including me. Though I haven't worked under her, she has always been inspiring with a very clear-cut views about what is going to happen. And today she's going to enlighten us about, in a short period of time, what happened at the American Diabetes Association and the American Association of Clinical Endocrinologists. Thank you so much, madam. Welcome to this edition of Diabetes News Nucleus.
Thank you, Dr.
Thank you so much, madam. So my first question to you, madam, is about obviously GLP-1 and high glucagon has been in our minds for the last 1.5 decades. But twin cretins, a dual GLP and a GIP, and it can actually change or probably get patients or people into euglycemic range and keep them there has been a new concept. So your thoughts about the SURPASS study with tirzepatide, and is this a molecule of the future?
So thanks, Raju. I think really I have actually worked on tirzepatide. I was one of the SURPASS investigators, and it is really a good drug. The SURPASS program, as you know, had 1, 2, 3, 4, and 5, where they have looked at as a monotherapy in SURPASS 1. Then they looked at different molecules, including glargine and semaglutide. And in all of those studies, tirzepatide has shown to have a great advantage, whether it is for glycemic efficacy or even if you are looking at weight loss or even reversal. Yes, in the SURPASS 2, that was what you were talking about. Roughly around 50% of people actually showed a HbA1c of less than 5.7, which is absolutely total reversal. And when I was working on the molecule, it is very easy for us to find out, though we had one arm as tirzepatide and the other arm as semaglutide, we knew that this molecule was there because even compared to that, patients were losing weight and their sugars were coming down much better. And it's definitely an exciting molecule to wait for and look for what happens with that molecule when it comes out in real world. Yeah.
Thank you so much. So it's been 100 years of insulin, which we are celebrating now.
Yes.
And insulin changed the lives in people with type 1 diabetes. Do you think this will change the lives in type 2 diabetes? Just because that till today, we didn't have an agent which could get us to euglycemia in people with type 2. And we don't know the effects of long-term euglycemia on our systems. So if we had an agent which could actually get you to 5.7 and keep it there, do you think it could change the way we are treating in future?
Absolutely. Because if you look at even, like, let me say, when I started 25 years back doing endocrine, we never had the concept of reversal. Now, of course, we have Roy Taylor's data. We had studies on bariatric metabolic surgery where they found that, yes, patients could stop medications and even reverse without any medicines. And I've had patients who had around 120 units of insulin who have gone back and not on any treatment and being reversed with bariatric surgery. So then we had Roy Taylor's data saying, okay, you can do a very low carb. But right now we have even so many other diet programs are there. You are aware of all of them, where they have looked at reversal in many of these programs. So now reversal has become a reality. How long reversal? We don't know. So this particular program also was very interesting because they took HbA1c of a very lower end only. They didn't even 8.8 or something like, and that range was what was their average HbA1c. And with that, they got a HbA1c reduction of about 2.5. Of course, they did different milligrams, 5, 10, and 15, where they got different results in the 3 groups. The maximum being with the 15 and the minimum being with 10, but not much of a difference. And of course, significant. But when you look at it in real world practice, when you say 2.1 and 2.2 may become significant, but in practice, it may not be so relevant. But it did show a good response. And I am hopeful. I always say this seems like magic when this drug comes. Of course, it has its side effects. I won't say it did not have. It had, and the side effects stayed for about 15 days to 1 month, and then it sort of plateaued, just like any GLP and GIP-1. It was comparable to most of the other GLPs, and there was nothing extra in this. And apart from that, it is a molecule I am looking forward personally to, because I have worked and we have seen those results in our patients from our center.
Thank you so much, madam. Let us go to something which we can use in practice today. Tirzepatide is probably the future. Your views about the GRADE study. For people who are listening to us, GRADE was a study where we always wanted to know which drug will marry metformin. And, we've had debates across the globe that, what is the best choice with metformin. So this is a prospective study done in the US where 4 groups of drugs, where you have an SU, you have a DPP-4, which is sitagliptin, you have basal insulin, which is glargine, and GLP-1, which is liraglutide, prospectively seen which does better. Over to you, madam.
So actually, again, I think this study was very well designed for that time. The design was started somewhere in 2009. That was when the concept was raised by, I think, Professor Nathan. And then it got implemented only in 2013. By that time, SGLT was not there. SGLT2 inhibitors had not come into the market. And pioglitazone was in a huge controversial problem. So those 2 very important drugs got left off. So we left with, actually that was at the time when DPP-4 was big. DPP-4, sitagliptin had got introduced and it had become quite big and people was very excited about the DPP-4. So, but yet we didn't have data. We didn't have data to say, okay, DPP-4 is better or SU was thrashed. And you know the story, how they said SU will cause the beta cell exhaustion and it will have, but the results came out quite different with GRADE. Of course, it was only a US based. So that was one of the drawbacks. They had very few Asians, I think about 180 Asians, but about 5,000 people and a 9.5-year follow-up period, which is a relatively good follow-up period. And interesting facts came out. Basically, efficacy-wise, everything was same. But what they found, the efficacy was maximum with sulfonylurea and liraglutide in the first year. And after that, at 4 years, almost every drug needed insulin to be added. That was their protocol, that these drugs, and if they didn't control, then you would put on glargine. So they found that the efficacy after 4 years was everything needed insulin. But the sad story was they found the least efficacious was sitagliptin. Of course, small study, and they also say that it should have been larger and more population should have been taken. But this is what they found. And they also tried to look somewhat like MACE and cardiometabolic outcomes as to say what is the cardiac outcomes that happen. And what they found was that liraglutide and glargine stood out. Liraglutide especially stood out way better as far as the cardiac outcomes were concerned. So yeah, interesting study. And and this shows that whatever we find when you're doing controlled trials may not actually can be extrapolated to real world evidence.
Real world.
So here, head to head, they studied and they found that actually not much difference between any of those groups after 4 years, and that was what they concluded. But of course, they came up with these few points. that the efficacy in the first year was best with liraglutide and SU. Cardiovascular metabolism was best with liraglutide, and efficacy also was very good overall with insulin and liraglutide. And long term, everyone lost their control after around 4.5 years. Hypoglycemia, as expected, was more with sulfonylurea compared to the others, and the weight gain also. Yeah.
So the jury on sulfonylurea is still not out. It's still there. It's still fighting its last battle. And very surprisingly, madam, whenever you speak to a Caucasian or a white professor, for him, a DPP-4 inhibitor is like a placebo. He thinks 0.5, 0.7% is what he gets. In India, do you think there is difference that ethnicity, we feel it works better, and this study purely done in the US with the white Caucasian population, would that have made the difference, or do you think it works the same way across?
See, thanks for the question, Rajiv. But see that this is actually something which we were trying to write a position paper on DPP-4, because that also has finished a decade or something like that. So the linagliptin was thinking of doing that, and they did show us some data that Asians. They looked at data of East Asians and Central Asia, and they said that the gliptins worked better in Asians compared to the Caucasians, and the HbA1c reduction was better. But it was small data, and so though it looked relevant and good, I would be a little hesitant to say that whether it is really much better in Indians and we would get a great HbA1c reduction. In fact, we get a much better HbA1c reduction with SGLT2 inhibitors. Even my own experience with DPP-4 is roughly around 0.5 to 0.8% reduction in HbA1c. But very good drug, doesn't cause hypoglycemia, doesn't cause weight gain. And again, in our country, we do get people who just lost a follow-up, and then after 10 years, they'll come and say, Dr. Mala, I just wanted to see you. I'm sure it's happening to you all the time too.
Everywhere.
So what is their GFR, and they've continued? Why did you not see somebody else? So for that, in those reasons, yeah, DPP-4 inhibitors are good. But yes, this is what the outcome of the GREAT study, which were, we were looking forward for the GREAT study for a long time. But somehow I feel now it's a little late in the day, because we have got such good molecules like SGLT2. Now we have talked about GLP, GIP. We have GLP, even Sanofi has got their new GLP with the Amplitude O study, which also was in
FPG and tide.
Yes, which also showed some promise. So we have so many molecules that we have sort of come away from just the sulfonylurea, metformin, liraglutide, or sitagliptin kind of a field. The field is much wider now.
Much wider. So that's what the grade does not fit into relevance right now, because in the last 5 to 7 years, the whole SGLT2 cardiovascular outcome with GLPs and everyone, that has actually captured the mind of all of us over a period of time. So grade, somehow if it had come a little earlier, in Bollywood terms, it's like in Bollywood terms, like a multi-star movie coming in today's world, where nobody watches them. But still, in terms of grade, there is some positives for the SUs per se. It's a good, on a prospective side, you're seeing that the SUs function better than a DPP-4 in both its HbA1c and durability, which is quite, the beta cell exhaustion story is still there. What do you feel about it, madam?
No, I have no belief in this beta cell exhaustion at all, because after some time the beta cell sort of gets up and starts functioning all over again in these reversal programs. So yes, maybe glucotoxicity, and it has sort of become less. We don't actually know why. But yes, the sulfonylureas have been beaten a lot. And in a country like ours, India, where, cost is such a big issue, and long term, and insulin prick is another big issue, I think sulfonylureas in the correct hands works very well. And I have not seen so many hypoglycemias as expected. People, if you say, oh, sulfonylurea causes hypoglycemia, you use the correct dose, whether you're using glimepiride or you use glycoside. I'm very happy with them, and we are using this continuously. Even now, I think sulfonylureas are still in the ORG mark data. The highest number of prescriptions are for the sulfonylureas. So I think they are here to stay. They've stood the test of time. I think they've also passed 50, 60 years of more than that. They've been around more than that. They've been around and they're efficacious. And if you look at the natural progression of disease itself, we all know that the beta cell, sort of by 8 years, 9 years, we are starting insulin in a large 60% of people. And whether the SU has got the beta cell exhaustion or something else has done, we don't know. So it is, I don't give any relevance to that beta cell exhaustion. And we also had the Carolina study, which again showed 4 years, linagliptin and sulfonylurea. The durability was the same for both.
True. I completely agree with you now, madam. Madam, shifting from type 2 to type 1, there was certain management guidelines which came from the ADA and the ACE on adults with type 1. And whenever we get an adult, for us, an adult today is also a question mark, because now diagnosis of diabetes has become so premature and early, whether it's a young adult or an old adult. But what they have specified is 35 and less than 35,
Yes.
which may not be young by Indian standards today, where we see young people with type 2 diabetes and MODY. They say that if you have a young diabetic and you suspect type 1, go ahead and do an islet antibody first, rather than how we would do a C-peptide to actually see whether, if it's a young boy, 10-year-old, comes with ketoacidosis, still when he gets better, you'd still do a C-peptide just for endorsing your clinical diagnosis of being type 1. They say do an antibody first. What is your view on that, madam?
See, actually, the scenario for the Caucasians and us is totally different. So the person would have been treated at the periphery, somewhere in the PHC. He would have got insulin or whatever. Even a youngster, let's say, he admits, he query diabetic ketoacidosis, he admits, then he comes to you. Now, he may come to you after 6 years, 7 years. Islet antibody is a good marker, no doubt. But we all know that the time it appears and disappears is also relevant, especially at 35 years if you're going to have a type 1 diabetic, either coming for the first time or at a later time. And that is why you had that list of antibodies that you had to do, right? Even including the recent one, so we just to do one antibody, and if you're positive to say you're type 1 or negative to say that you're not type 1 is a little bit difficult. And in our scenario, I still feel control the sugar with insulin, send off a C-peptide, cost effective also to do a C-peptide and islet cell antibody. But if you look at their algorithm, not too bad. Do an islet cell antibody. If it's positive, you treat them as type 1. If it's negative, then they divide it into less than 35 and more than 35. But they're also at the end, they are doing your C-peptide. They say less than 200, definite 200 to 600, and more than 600 type 2. So the 200 to 600 is the gray zone, where they say if you have some, you follow it up. And of course, if you have any MODY symptoms or signs, then you test for MODY. Otherwise, if it is 200 to 600, and if you have some symptoms of signs of type 1, you can say type 1. And if it's more than 600 picomoles per liter, there's no doubt that this is a type 2. So it's a new way of thinking. I have worked with Professor Jaakko Tummelhetto in Finland. I was part of the Diamond project, where we tried to do an epidemiology for type 1. Interestingly, there, every patient of type 1 you can understand both primary and secondary collection of data. You can pick up each and every type 1 because their registries are so good. Unlike in our country, when I was trying to do, people will go only to the pharmacy and they will take the drugs and go. They never come to the doctor, or they have died somewhere as with type 1, and you never get to know whether they're type 1 or what they died about for. Now, of course, little bit more awareness is there. But even today at PHC level for a type 1, the awareness is not that much as it is for type 2. So that is a new way of thinking. I think it's okay for the Caucasians, but for us, it's a good tool. But again, in private setup, very expensive. Even looking at C-peptide in our own medical college, C-peptide is something like 1,000 rupees, while antibody is 4,500.
4,000.
So yeah, it is.
So what Madam is telling us in a nutshell is that don't try to jump to a diagnosis, isn't it, Madam? If you have a patient
Yes.
who has osmotic symptoms, weight loss, don't try to categorize him as type 1 or type 2 or LADA or whatever. Treat him with insulin, do a C-peptide. You can reclassify him always, but first treat him, get his C-peptides, get his done, then you reclassify him, that would be.
Yeah.
True, madam. Go ahead, madam.
No, that's what 3 months later he will come and you can reclassify. The diagnosis is not so important. Of course, it's important at the end of the day because whether to continue or not. But treat the patient. He comes with so much psychosocial problems, and especially type 1. Someone would have told you need insulin lifelong, which is true. But the way you say it and his psychological setup, he needs counseling. He needs all the education. So all that needs to be first garnered, and then possibly after that you find your diagnosis and say, okay, this is what you have.
True,
yeah.
True.
Yeah,
man, go ahead.
And I just want to tell everyone this type 1 diabetes and lipid dystrophies, they can look same. So you people out there, please think of that also when the patient comes in looking like a type 1 diabetes.
Right. Also, some data at the AACE about polycystic ovarian disease and they're getting premature cardiovascular disease. So as in diabetics, we need to prevent events. These people are lost. Once probably they come to you for infertility or probably cosmetic issues, and then they are lost, madam. And especially in India, So, is there any policies everyone should follow, like in people with diabetes? These are at higher risk for cardiovascular events.
No, I think the two places where you have opportunities of prevention, you should just dive deep in and prevent cardiometabolic problems, both in girls who have polycystic ovaries or young women with polycystic ovaries and gestational diabetes. These are two catchment areas which we need to prevent. We have published one data where we've looked at internal carotid intima media thickness of polycystic ovaries, and this average of this girl was only 18 years, and there was a difference between significant difference between of 0.4 millimeters between polycystic ovarian girls with and normal girls in their intima media thickening of the internal carotid artery, which is which is really something which shocked us. Actually, we didn't think that it will be so significant. So it is there, and we need to counsel our children and our young women. And also we need to, like you rightly said, maybe make one algorithm, because all this, when gynecologists treat, they see a lot of polycystic ovaries. For them, it is just fertility. They may maximum look at glucose. They are not looking at what is the outcome of glucose in the later time. So I think, like you rightly said, some organization, all of us together should sit together and say, okay, PCO, apart from just diagnosing, we all have a lot of algorithm for diagnosis, for diagnosis of PCO. But then after that, what? Like now, if you have Turner, they'll say 5 years you do an echo, 5 years you do a sensory neural deafness testing. But for polycystic ovaries, we don't do. Even if you see polycystic ovaries, how many of us get a GTT done?
True.
We'll do one fasting sugar, and fasting sugar is not at all the problem in PCO. It is the postprandial sugar which is a problem. So we to understand whether they have diabetes or pre-diabetes, and they're all obese and they're so insulin resistant, and we know that the common soil hypothesis, insulin resistance, is the cause of cardiovascular morbidity and mortality. So I think we should, especially in India, put down these guidelines for every physician out there, that they should follow. Very simple, not very elaborate and complicated. Simple algorithm. Okay, this child comes, please do a glucose, please do a lipid profile, and whatever. And obesity, it's not that the girls with PCO start eating more and they become obese. They are insulin resistant, and the androgen cause prevents satiety at the hypothalamic level. So that is why for them to be satiated and to lose weight is such a big challenge. And here the mother will be nagging. She doesn't do this, she doesn't do that. She's all the time on the laptop or the mobile. And she does that not because she wants to, but basically because she's fed up of the nagging and the negative image conscious they have. All this together puts her into a shell. So these are a few things that, this is a very complex area, the polycystic ovaries, and very controversial too. But yes, I think a very important point you have raised of the cardiometabolic thing. And this is my area of interest also, that, these women, young women who have the whole life ahead of them, this is where we should target. So that, and you rightly said that we have premature cardiovascular. So even normal people who don't have a diabetes, they have, we see heart attacks in 35, 40 years. What about these girls who are so young, and we know when they are diabetic or insulin resistance, the protection of the female hormone is gone. So it's very important that we should look at it and counsel them and the physicians to look for all these risk markers, so that we can look at it as a whole and not just, like you said, cosmetic or getting their cycles or things like that.
That's a very important take-home message from Madam, that anyway there is gender disparity in India when it comes to healthcare. Women somehow do not get the same kind of healthcare facilities as men do, and this kind of opportunity screening for people who have PCOS or who were GDMs actually gives us an opportunity to pick them up early and prevent a lot of metabolic problems, whether it's cardiovascular, diabetes, and so many else. And she also spoke about the common soil hypothesis. So, Madam, just a last question, because you alluded to amplitude O and FP glinatide, and you think that this exentin 4 never had a positive study. None of the exentin 4's GLP-1 analogs as such. This is the first time that they had a positive study. So, do you think the human based and the exentin based are similar, or you think they are different? Or, what's your view on that?
See, actually, I do believe GLP-1s are similar. The reason why they did not get a positive outcome, this is not my view, I read it in a review, was that when you did liximatide, that had to be given twice a day, but they gave it on, that was also a Sanofi product. They gave it once a day. So that is why they didn't get any benefit. And this is what the reviewer had reviewed, and that was his understanding. And I sort of thought it must be true. So when they have done and compared it with dulaglutide once a week, and it seems to be exciting, but we have a molecule in that space. We have dulaglutide, and we have, again, I think...
semaglutide also.
Semaglutide coming. So an oral semaglutide. Now that will be a screen changer. That when you have this oral semaglutide, we are afraid of the prick. We have to sort of accept it. So I think that if it comes, it would really be some scene changer for us. Oral semaglutide. But yes, it's interesting. It's always good to have more the merrier. You have a choice to write whatever you want.
Absolutely. You have a buffet approach to the patient in terms of one drug itself. Choose which once a week, once a day, oral twice a day. So thank you so much, Professor Mala. Thank you very, very much. You know, when an expert like you comes and gives the insights about it, I believe a lot of delegates watching you would have learned a lot, and I believe this is what would enrich their practice. Thank you so much for being with us, and thank you all of y'all for listening in to this 9th edition of Diabetes News Nucleus. And we will be back with you next month again with whatever is happening latest in the metabolic space, and with a new expert who would give their insights about what is happening in the new space. So thank you so much for a patient hearing, and I hand it back to the organizers and Dr. Prashant to take it forward. Thank you so much, madam. Thank you very, very much.
Dr. Raj, pleasure.
Thank you, ma'am. Thank you so much. And thank you, Dr. Kovalser, for beautifully moderating this session. And of course, I agree, Professor Mala Dharmalingam is such an expert. Definitely, our audience must have benefited from her talk. So, ma'am, thank you very much. And on behalf of Mankind Pharma, I thank you all for participating in this session. And I thank all the audience who have joined us in this session, the 9th edition of Diabetes News Nucleus. So, thank you, ma'am. Thank you, sir.
Thank you.
Thank you so much. Stay safe, madam. See you soon. Thank you, ma'am. Bye-bye. Bye. Bye, Prashant. Bye.